what really causes endocrine pathophysiology. So we know that hormones go and they are binding to the binding protein. They go to the site where they are either activated or inactivated. They act upon their receptor, and that effect of the receptor has a inhibitory effect on the so suppose your thyroid hormone goes up, the FT4 where the FT4 will go and the T3 will be converted, your TSH will come down. And the body will need to sense about that to see whether the levels are high or low, and according to that, it will start acting. So now on this perspective, Manoj, what are the possible ways in which you can have hormone deficiency? So what are the pathophysiological basis of endocrine deficiency?
Gland is not found.
Okay, so your gland is defective, development is a problem. Then
Gland is found, but synthesis is not about.
So gland is formed or destroyed. So structural problem will be there. Next, you are saying there's a problem in the hormone synthesis or the hormone release. It's not being released. So it's formed, it's not released. Then
Transportation is not occurring.
so if there is a problem in the binding protein, you can have a sequestration. So that happens if you have too much binding protein, it will cause a problem. Then if you have a problem in,
there is lots of inactivation, then it can't.
yes, so reduced activation, you have got inactivation. Then what else?
Receptor problem.
So receptor problem may be there, resistance. Then you have a sensor problem. So sensor is sensing more. So then you will have an increased effect. Now you give me quick example. Of course, we know synthesis problem, destruction, all those things we know. What could be the example of increased sequestration causing a disease? Or worsening of a pathophysiology sign. Increased binding causing a problem. Somebody who has a multiple predatory hormone deficiency, who is on hydrocortisone, you start estrogen, your binding globulin becomes more, you will have deficiency. Problem of deficiency of binding protein will be excess, which will come on to that. Then activation problem, sign. Endocrine disorders because of activation problems. 5-alpha reductase deficiency, very simple. Aromatase deficiency, these are activation problem. More inactivation. In what conditions you have got more inactivation of a particular? So if you have got a disease like situation in which you have got more inactivation, you will have that alteration in system on that. Receptor problem, of course, we know there are a huge number of receptor problems starting from pseudo hyperparathyroidism to growth hormone insensitivity. So this is nothing to worry. What about sensing? So sensing defects will be, so calcium sensing, the body is sensing too much. So activating defect of the calcium sensing receptor. Glucose is being sensed more. So you will start developing, when glucose is more, you will have hypoglycemia. So all these problems can cause a deficiency. Now, if you ask me, I would say the most common, of course, will be the gland developmental issues, which will present much earlier. They will present typically in the newborn period. Then you can have a problem in the synthesis of the particular gene, those gene defects. They may present a bit later, 1 month, 2 months in that perspective. Problems of release, like insulin release, that a classical example is insulin release, which you will see in the setting of potassium ATP channel defect. They will also have a problem, which may happen in the form of diabetes. They will have an early presentation in that perspective. Then a big group will be resistance, which is there in that perspective. So now endocrine excess. Vibha, what do you think conditions can cause endocrine excess? So one, of course, it is producing too much because usually you have a tumor or your gland has become more. So this is producing more. What else? So second is your gland is damaged and the hormone is released, which is classically happening in thyroiditis. Then binding protein, what is happening? So low level of binding protein condition which causes this. So which condition is caused by deficiency of binding protein or lower binding protein, and you have a problem? hyperandrogenism. In hyperandrogenism, you have got more androgens which inhibit SHBG. SHBG becomes less. The binding of androgen to SHBG becomes less and the free testosterone level goes up. So therefore, again, low binding protein may have a problem in that perspective. Then release of store is there. Then binding protein problem, you said. Then increase activation. Any condition? Any condition, sign of activation of a enzyme which is causing increased production? A boy presenting with tall stature. And gynecomastia, aromatase deficiency. Aromatase excess will be the scenario. Inactivation, reduce inactivation. Example? Which condition is associated with reduced inactivation causing excess? You have a child whom you have given vitamin D and he presents to you with polyuria, abdominal pain. You do the calcium levels, they are high. So the problem is, so your inactivating enzyme 24-hydroxylase is not active. So you get everything is converted into calcitriol. So all these conditions can cause that. So if you now use this diagram, you can explain nearly most of the causes which is there. Then of course, you can have a receptor overactivity. Overactivity is more common or underactivity is more common. Matlab resistance is more common or sensitization is more common. Resistance is more common. Why? Sign? Why do you think that we have got so many PTH receptor problem, growth hormone receptor problem, but the hyperactivity is less common? Because if your receptor has even single defect, if you're building, you take out something, it will collapse. So anywhere you do damage, it will collapse. But for something to work more, you need a very, very unique situation. And if you remember, most endocrine excess because of receptor are which type of hormones? Peptide, amine, or steroid. So peptide. You've got TSH hyperactivity, you've got LH hyperactivity, which is testotoxicosis. You've got GNAS problem. They are all of them, macunal, right? They are all acting via the peptide hormone. So classically, hormone excess because of a receptor problem is a peptide problem. Do you have steroid problem in terms of resistance? Resistance very rare. Why very rare? Glucocorticoid resistance, estrogen resistance, ES1 defect. So these are known. 5-alpha reductase about androgen insensitivity. So what I'm trying to say is that insensitivity can happen very easily. If you want somebody to not work, is it easier for you to get people to not work? You will beat him up and he will not work, and you will beat him up to do more work. What is easier? So for doing extra work, you need some extra caliber. They need to have something else. So receptor has to change in our orientation that it's actually working. Generally, when you have a receptor problem, it will become silent. So you will have a deficiency. To make it more active, you need to have a unique position. So that is typical of, let's say, the RET oncogene. There you have the increased constitutional activation. And constitutional activation classically happens in peptide hormones. That does not happen with steroid hormone. But we were thinking of rare cases could be glucocorticoid sensitivity, in which your glucocorticoid is working more, but very, very rare in that scenario. So endocrine excess can be because of increased production, release, reduced binding, increased activation, decrease in activation, overactivity, or a sensor problem. If the body says, okay, the levels are low, your calcium levels are low, but it will start producing more amount of PTH that will cause your hypocalciuric hypercalcemia. If body says your glucose level is too much, it will start producing more insulin. What will happen? You will have hypoglycemia. If body senses less glucose, you will have diabetes, which will happen.